This is a short case discussion. This is a 37-year-old gentleman from Vellore who has presented with a chronic progressive weakness and thinning of all four limbs for a duration of 18 months and speech disturbances for the duration of 6 months.
Okay, with just the chief complaints, can you give a gross localization where all the lesions can be?
Yeah, so this it's a progressive weakness and thinning. So there are a bit of all four limbs, and predominantly it's an element syndrome. Element can be involvement of the anterior horn cell, can be involvement of the motor roots, or it could be nerves, or it could be because of the neuromuscular junction or muscle. To differentiate these, we need to know a little bit more on the history. And speech disturbances, it is for 6 months duration. Speech can be either because of, it can be either it's a dysarthria, or it can be aphasia, or it can be dysphonia. Again, more on the history can give a little bit more clarity on this.
Is there any way you can combine both to a single localization, or it's very difficult as of now?
It could be all weakness of all four limbs with speech disturbances can be seen in element syndromes. Can be seen because of any muscle involvement. So that can also be a possibility. So I would be looking at the history. Would be looking at whether there is any features of any myopathy, any neuromuscular problem, or any neuropathy. Mainly a myopathy and neuromuscular problem is what I'll be looking at.
How about brainstem? So brainstem causing speech disturbances as well as weakness.
Yeah, if there is, we can think of brainstem if there is involvement of cranial nerves, which can also help you with that. But there's no involvement of cranial nerves in the history. Speech can be, but again, I'll be looking at any features of any nasal regurgitation and things such as a bulbar symptom to point at as a bulbar as a symptom.
Yeah, so those are the things that will, just from the chief complaints, we'll be going ahead and asking more detailed history, because patients may not complain of like mild facial weakness, they may not complain of tongue weakness, for example, often is not complained of. So on history, and when we are examining, we have to be extra careful in these things. Okay, go.
So this 37-year-old gentleman had an insidious onset. Initially started with difficulty in holding his pen while writing bills in the shop, gripping objects and mixing food and buttoning his shirt in the right hand initially. Followed by he had difficulty in some few months, had difficulty in reaching for objects which was placed in the upper track of the shop, had difficulty in shampooing, combing his hair. Subsequently, 6 months later, had similar symptoms even in the left hand. And then 8 months onset of symptoms, he developed difficulty in getting up from squatting position from a chair, climbing steps, and also gripping his footwear with twisting of the ankles. There is no history of any fluctuation of symptoms.
Just go back and summarize that in one line.
He had both distal asymmetric onset, distal and proximal weakness of both upper limbs and lower limbs, which progressed over 8 months.
Yeah, so asymmetry is there, and distal is more early, and then later on. So upper limb is first and then lower limb, is it?
Yes, sir. Upper limb first, followed by lower limbs.
Right. So some of these things we can mention in the chief complaints as well. Distal weakness or proximal weakness, if it suits. Not necessarily, but sometimes it may be helpful. You can have a localization there and then itself. Okay. So the weakness is still not, it's still not very clear. Are you coming more?
Yeah. Okay. Then there was... of his hands.
So shirts and pant becoming loose is not wasting of muscles per se. So yeah. It's a generalized weight loss. So you have to be very clear that it's a muscle wasting, thinning of limbs, furrowing of guttering of hands. So if the patient has generalized fat loss, then pants will become loose. Otherwise, that doesn't make sense.
And there was history of twitching of muscles of both his thighs and arms. And he was also saying that his upper limbs were very loose while walking.
So feels loose is more important than swing loose. So they'll generally feel okay.
These are the motor symptoms.
Okay. So with motor symptom, do you want to add any other system at the same time quickly, if it is normal or abnormal, negative?
In the sensory.
Yeah, so generally sensory goes along. So in subsections in CNS, when you have higher motor functions and extrapyramidal, then cranial nerves, then brainstem, then motor, sensory, autonomic, and cerebellar. So we have to go through each of the system, but the most important you said was motor. That's why I went to motor first. And at the same time, you can cover sensory also, if there is any positive, or you can just say there's no sensory symptoms. Is there any sensory symptoms?
There is no sensory
Okay.
symptoms.
So there is no sensory symptoms. So grossly, where do you want to localize it as a UMN disease or LMN? You want to stick to LMN?
LMN.
Right. So there were no features of UMN, rather fasciculation, wasting, if it is there, guides us more to LMN. Now, where in LMN would you want to
Because
guess
it is
now?
asymmetric, it could be because of the anterior horn cell disease.
No, not because of the asymmetry, because of something else.
Distal fasciculation.
Twitching is there, no? So twitching is more likely in anterior horn cell. So, so asymmetry is not localization, is not this thing. That's a disease related. Okay, anything else? Is a nerve localization possible?
There could also be motor nerves.
Pure motor nerve, okay.
Motor roots, but less likely because distal also is involved.
Right. No, so distal again, which root is involved? No? So if the C8 is involved, we'll have distal weakness. So that's not a localization. So it's not a root specific per se. Okay. And no sensory, so mixed nerve becomes less likely. Okay. Muscle and neuromuscular junction is out? Very unlikely or still possible?
For both, you'll be having, mostly they'll be having a lot of symmetry and it'll be proximal involvement. There'll be fluctuation seen in neuromuscular junction, which is not seen, and there's wasting in all.
Yeah, neuromuscular junction is less likely, but muscle you can still have. Some diseases have rippling. Some disorders can cause features like, so that is something that you'll clear off on examination. Okay, go ahead.
Approximately 1 year from the onset of symptoms, the relatives noticed that his voice became very slow and effortful. He frequently chokes while drinking water, and there's no history of any nasal regurgitation. And there's also a history of significant weight loss of 7 kgs over the last 6 months.
Right. So, what is the is this a language abnormality, speech abnormality, or dysphonia?
It's a dysarthria.
Yeah. Which type?
It's a spastic type of dysarthria.
Right. Okay. Okay. Go ahead to next slide.
Otherwise, there's no any history of any memory disturbances, no sensory symptoms, no bowel or bladder disturbances, no significant past history, personal history, or no significant family history.
Okay.
They're summarizing a 37-year-old gentleman presented with asymmetric distal onset progressive weakness of all 4 limbs with thinning, twitching of the muscles, difficulty in swallowing, and slow, effortful speech without any sensory or bladder involvement. So it's a pure motor syndrome. I will localize into the anterior horn cells and other area of localization is motor nerves. Patient had a spastic speech.
So, what examination will you focus on quickly? You're short of time.
I would
cranial nerves.
Cranial nerves and his motor and sensory.
Go to cranial nerves then.
So, yeah, there is. So we checked his speech. So this is the way he spoke. Sounds.
Okay, we'll come back. We'll come back to it. Just finish up the rest of the exam.
Otherwise, there was a brisk jaw jerk. There was no other facial weakness. Uval and palatal movements in this were symmetrical and is equal. Gag reflex was exaggerated.
So there is atrophy as well as a brisk jaw jerk, right? So there are UMN and element signs. That's what it's saying. Okay.
And his tongue movements were very slow, and there was fascics present on.
Is there a video?
Examination.
How do you check for fasciculations in the tongue?
Make sure that the tongue is
not protruded out. Otherwise, you can get false positives.
In the
tongue
oral
should be
cavity,
inside.
and then.
Are they seen? Difficult to make out. No? Okay, we'll take your word for it. Okay, go ahead. So tongue movement slow also can be there in both element and UMN. Make sure that the tone which you can examine by palpation of the tongue is increased.
So on motor examination, there was proximal and distal wasting in both upper and lower limbs. Tone was spastic in all 4 limbs, and there was at least 4/5 power in all 4 limbs. There was a weakness of both the intrinsic and extrinsic. There was weakness of the intrinsic muscles of the hand.
So what do you see? Just keep describing.
Finger drop with. There's a part.
Which
the
fingers
wasting
are
of the
dropped?
intrinsic muscles.
Yeah. So on the right hand, which fingers were weak? First and second. No?
Yeah, they be.
So is it a claw?
The left side there's a clawing. Which is the left
So
side.
yeah, this also you can call it a claw. It's more of a median claw rather than, but yeah, not a typical ulnar claw. Okay, go ahead.
And there was also fascics. Can we see in the pectoral region?
Yeah, okay. Right.
There were sensory examinations within normal limits. Reflexes were all exaggerated. And he had ankle clonus.
Yeah, okay. Okay.
And he had a spastic gait. There was a 37-year-old gentleman who presented with a pure motor syndrome or progressive weakness of all 4 limbs with bulbar symptoms. On examination, he had both UMN signs in the form of spasticity, exaggerated reflexes, and element signs with atrophy and fasciculations in both bulbar and upper and lower limbs.
Still your diagnosis? Localization and diagnosis?
Localized to the, it's a pure motor syndrome with localization to the anterior horn cell.
Okay.
The other differentials I would...
What's the diagnosis? First diagnosis, then differential diagnosis.
It's a amyotrophic lateral sclerosis.
Okay, what is odd in him for amyotrophic lateral sclerosis? Age, no. So 37-year-old, you don't
Yes,
get
sir.
typically age. That's why you have to consider all the other differential diagnoses.
Yes, sir.
Yeah. Was there any pseudobulbar effect?
No, sir.
Was there?
It's not there, sir.
Not there. Okay. Okay. So I don't think we have time to go through the differentials. So
Yes.
it will be important to do
Just
the
few things is
rule out
any
these
patient
differentials.
with ALS always look for any multifocal motor neuropathy with conduction block. It's a treatable condition. Also, always any patient who you suspect ALS, get a screening of the brain and the spinal cord. Look for any compressive
Yeah, but those
myelopathy.
patients won't have bulbar symptoms. No,
No,
that's why I have to. Okay.
And other is heavy metal toxicity also should be considered for patients. They'll have which is treatable conditions.
Yeah. So what tests will you do? Just 2 tests.
MRI brain
Imaging,
and spine
yeah, more
screening
important.
and NCS studies also.
Yeah. More important than conduction will be imaging to
Yes.
rule out. Okay. Sure.